Now, I'm sure that everybody listening to this is all aware that the UK healthcare landscape is an extremely complex topic, which comprises of multiple layers of various types of structures and stakeholders. So we'd probably be here until this time next week, even if we tried to attempt to untangle half of it. Therefore, this is a whistle-stop tour which focuses on some of the areas which are pertinent to market research and also the reach that GKA has in terms of respondent types. Okay, to start us off, let's take a look at the different grades of doctors that practice within the secondary care or hospital environment. So the structure is fairly straightforward, with medical students entering into a 2-year foundation programme once graduating from university. Foundation years have now replaced the roles which were formerly known as house officers and senior house officers. Now, during this bridging post, foundation doctors have the opportunity to gain experience in a series of posts in a variety of specialties and healthcare settings ahead of entering their specialist or specialty registrar training programme. These are tailored to the needs of the chosen specialty and typically span years 3 to 8 of their career. Consultant posts can then be applied for once doctors have a minimum of 8 years of training under their belts. As this slide suggests, GKA recruits specialist registrar and consultant grades, as these are the clinicians who make treatment decisions and have the ability to prescribe and carry out pharmacological interventions. However, trust grade and associate specialists should not be excluded from scope, as they have similar responsibilities in terms of patient interactions as their specialist registrar and consultant colleagues. A trust grade doctor is a clinician who is appointed to perform a permanent position as a middle grade doctor, therefore equivalent to a specialist registrar. Now, in order for a doctor to work as a trust grade, he or she must have at least 6 years experience. They've been appointed to this position based on their experience, which may have been acquired outside of the UK and can be a contributor to them not entering into the specialist registrar training programme. Associate specialists are comparable to the consultant grade, and they typically work across many hospitals. They're often not responsible for the teaching and supervision of medical students and junior doctors, and will generally perform less management duties. However, they do spend more time on patient care, resulting in them being a particularly relevant sample. Even the associate specialist grade, or even though the associate specialist grade is no longer open to new applicants, there remains approximately 6,000 associate specialists in England alone, displaying that these should not be dismissed as a hospital grade. Let's now take a look at the NHS banding system, which has been radically overhauled in recent years. As implied by this slide, the traditional banding used to be based on alphabetical lettering system, ranging from A to H. Now, this had inherent problems, as many nurses had the same responsibility as others who are of a much lesser grade. The new system is based purely on pay brackets and comprises of 9 in total. You can see some examples of nurse-related job titles listed down the right-hand side of this slide. You'll notice that I've not included band 9, where pay ranges from £80,000 to £100,000, as this scale is not relevant to any nurse roles, but includes chief financial and directorship roles. This pay system covers all NHS staff except doctors, dentists, and very senior managers. Each of the 9 pay bands has a number of pay points, and staff will generally progress to the next threshold annually until they reach the top of their pay band. Again, this is another consideration when designing recruitment questionnaires, as the nurses we typically recruit may now be clustered in the same bands based on their salary, resulting in quotas being unachievable. In fact, as banding now has a direct relationship with pay, nurse band quotas are somewhat immaterial for segmentation purposes, as the vast majority we recruit will now fall within bands 5, 6, and 7. You may be surprised to learn that there are no official definitions to distinguish teaching hospitals or district general hospitals, or DGHs as they're currently known, especially when the vast majority of screeners ask this exact question. We regularly have to work with quota splits in terms of hospital settings, And we're finding that it's becoming increasingly difficult to recruit from DGHs, as clinicians use their own judgment to decide whether their centre is a teaching hospital or not. Let's take a quick look at some common assumptions of what these different settings are. So a teaching hospital is generally understood as a centre of secondary or tertiary care in a major city that's affiliated with a medical school. They often have a large academic department and a reputation for excellence in research. On the other side, a DDH, although being a major provider of secondary care in the local area, traditionally lacks a research focus. However, in recent years, this distinction has become blurred, as many district generals have now become part of medical schools and are actively involved in research. This has become an area of much confusion, not only for researchers, but also for clinicians. And when asking this question over the phone as part of a recruitment screener, the typical response we receive is, well, do you know what? It really depends on how you're defining it. A tertiary centre is usually for inpatients, and these receive referrals from both primary or secondary healthcare professionals. These specialist centres include personnel and facilities for advanced medical investigation and treatment. Examples of such centres include cancer, cystic fibrosis, multiple sclerosis, idiopathic pulmonary fibrosis, and haemophilia, amongst others. The numbers of these centres is limited in the UK, so we will always base feasibility assessments on the potential limitations this imposes when screening criteria includes prescribers of novel therapies within such therapy areas. Some NHS doctors will also spend a proportion of their time dedicated to private caseload. However, it's important to note that it's rare to find a doctor who solely carries out private work. Okay, to round things off, let's finish up by looking at some of the payers in the UK. So at the top of the pile, we have NICE. Now, at GKA, we've attempted to recruit NICE personnel in the past, but we've been advised of a blanket ban towards market research activities due to potential conflicts of interest. Therefore, we recommend to avoid targeting these job roles and tackle this from a different angle via KOLs who act as NICE advisors. C-suite respondents also sit high within the NHS hierarchy. Now, C-suite is a widely used slang term used to collectively refer to organisations' most important senior execs. It gets its name because top senior exec titles often start with the letter C, like chief as in chief exec, chief operating officer, or chief information officer. We've also seen this terminology applying to IT management roles too. I'm sure it will not come as a surprise to you all that the access to these types of roles is restricted and engagement in market research activities is low. These are very high level, busy people, and hospital receptions often will not put recruitment calls through, especially when our recruiters mention market research as being the topic. In these instances where they do manage to get through, we generally end up speaking to the gatekeepers. Respondents generally refuse the invites by their secretaries due to lack of time, or more frequently as trust policy prohibits them from participating. The vast majority of market access market research we carry out focuses on those payers who have the ability to heavily restrict drug usage or commission use of new drugs within the CCG. Those people who carry out the cost-benefit analysis at this level are medicines optimization personnel, formerly known as heads of medicines management, who typically have a pharmacist role background. Other types of stakeholders who have a say in these decisions include GPs who sit on CCG boards or appointed CCG leads, and also secondary care chief pharmacists. Clinicians who are active members of the drugs and therapeutics committees are also expert stakeholders who have influence over what drugs are brought forward for formulary inclusion. Clinical directors and heads of department can champion certain therapies and present health economic data to identify cost efficiencies via valuable data such as numbers needed to treat or long-term cost offsets through prevention of hospitalisation. Here we have to manage clients' expectations of their sample size, as these respondent populations are small, and clinical directors, by the nature of their role, means that they have fewer patient interactions and are mainly office-based. Similar to C-suites, this means that it's difficult for recruiters to get past gatekeepers and getting access when cold telephone recruiting. Overall, we feel that we can deliver a sample of approximately 50 payers. However, we look for client flexibility on job title, as it's important to note that responsibilities have been found to be more relevant than specific title due to regional variations, and also for flexibility on regional quota splits to achieve the number of completes in the payer environment. Thanks for your time, for taking the time to listen to this.